Welcome back to Medicine Deconstructed. I'm your host, Dr. Jay Rutland. You guys all know I like to talk imaging. I love looking at pictures. But today, we're going to get into the differential diagnosis of cystic lung disease. Let's go a little bit deeper right now. Cystic lung disease is something I see all the time. Most might freak out a little bit when they see cystic lung disease on a chest CT, but just understand the differential diagnosis. This will help you. Diffuse cystic lung diseases are a group of lung disorders characterized by the presence of multiple regular or irregular spherical parenchymal lucencies bordered by a thin wall and having a well-defined interface with the normal lung, like this. You can see the cysts on this CT. Cysts can be caused by cancers, they can be congenital, they can be caused by lymphoproliferative diseases, infections, interstitial lung diseases, you know I love those, smoking related, and some can look like cysts but really be something else, like bronchiectasis or emphysema, which is dead lung. If you need a reminder on how to read CTs, watch my episode right here. Otherwise, keep listening in. When you see cysts on CT in a non-toxic appearing patient and infection's been ruled out, I'm going to arm you with a differential. Let's get into the etiologies. I'm going to talk about one neoplastic etiology. We're going to talk about a condition called Lymphangiomyomatosis, or LAM. LAM is an uncommon cystic lung disease caused by the infiltration of the lung parenchyma with smooth muscle cells via the blood or lymph tissue. It causes bilateral thin-walled cysts, typically in reproductive age females. A lot of these patients are going to have a condition called tuberous sclerosis. The average age of diagnosis is about 35 years old. Patients might present with a pneumothorax because one of these cysts actually popped, causing an increase in pressure and a collapse of the lung. Patients may have a mutation in the tuberous sclerosis genes, TSC1 or 2. These genes are responsible for making the proteins hamartin and tuberin. They regulate cell growth. So if you're deficient, you're going to upregulate this mTOR, this rapamycin, which leads to inappropriate cell proliferation and migration. You get foci of smooth muscle cells that stain for actin, vimentin, desmin, and estrogen receptors or progesterone receptors. The cells also react with a monoclonal antibody called HMB45 that binds to GP100. You want to check your vascular endothelial growth factor D levels, and you also want to treat this condition with sirolimus while possibly awaiting a lung transplant. Another neoplastic cystic lung disease is pulmonary Langerhans cell histiocytosis. It's usually diagnosed in young adult smokers. People present with shortness of breath and maybe even fever. They may also present with a pneumothorax. The pathogenesis is the accumulation of Langerhans cells, which are basically dendritic cells, antigen-presenting cells. Smoking stimulates the production of macrophage colony-stimulating factor, TGF-beta, and possibly osteopontin, which recruits monocytes, Langerhans cells, and dendritic cells. The CT scan typically looks like this. The cells first like to accumulate around the respiratory bronchioles. To diagnose, we biopsy the lung and we stain for S100 and CD1A. Treatment includes, quite simply, smoking cessation and steroids or maybe even chemotherapeutic agents. Not everyone thinks of this, but there are also non-Langerhans cell forms of histiocytosis, like Erdheim-Chester disease. These cells stain positive for CD68. Malignancies can also present as cystic lung disease. Sarcomas and mesenchymal tumors. Lymphomas can as well. There are other smoking-related interstitial lung diseases or smoking-related lung diseases that can present with cysts. Discriminative interstitial pneumonia or respiratory bronchiolitis interstitial lung disease present in this way. They're basically a continuation of disease. You develop an accumulation of pigmented macrophages in the bronchiole and eventually in the alveoli. That's when RBILD becomes DIP, when that macrophage is in the alveoli. Obviously, infection can cause cystic lung disease. This is pretty easy, right? That should be probably first on your differential if the patient's in the hospital and toxic appearing. Pneumocystis jirovecii, commonly seen in immunocompromised individuals, especially patients with a low CD4 count, presents with pneumothorax and thicker-walled cysts throughout. We call these cysts pneumatoceles in this case. Staph aureus can cause cysts as well. I saw this just this last weekend. And Paraganglomatosis, which is a zoonosis caused by an oriental lung fluke called P. westermanni, after ingestion of freshwater crabs, can cause this as well. This is pretty much endemic in Southeast Asia. There are a host of interstitial lung diseases that present with cysts. IPF, hypersensitivity pneumonitis can look this way, and even sarcoidosis. LIP, which is an idiopathic interstitial pneumonia, also presents this way. You're going to see bilateral thin-walled cysts throughout. Sjogren's syndrome, which is an autoimmune disease, a connective tissue disorder, presents like LIP in the lung. Finally, there's autosomal dominant disorders like Birt-Hogg-Dubé. This is a syndrome, and like I said, it's autosomal dominant. It's characterized by hair follicle tumors, renal neoplasms, and pulmonary cysts. The cysts are typically seen in the 4th or 5th decade of life. BHD, or Birt-Hogg-Dubé, is caused by mutations in the folliculin gene. Finally, light chain diseases like amyloidosis can cause cystic lung disease. I don't want you guys to be intimidated by a CT scan that looks like this. Just run through your differential diagnosis, which is going to include things like pulmonary Langerhans cell histiocytosis, LAM, Birt-Hogg-Dubé, LIP, interstitial lung diseases, and infection. Think about these things, put them on your differential, ask the patient what they've been through in their life, think about their age. This is going to help you narrow down what it is, and it's also going to help you identify how to treat it. We'll see you next time on Medicine Deconstructed.